Hello everyone, I am myself Dr. 𝗓𝐬𝐽𝐫𝐢𝐻𝐫𝐢. I am the general medicine educator. So in this particular section, I will be discussing some of the very important clinical based questions in the topic of the cardiology. So starting with the first question, we have one 65-year-old male patient with a history of hypertension and previous myocardial infarction. He presents to the emergency department with complaints of the dizziness and near fainting episodes. ECG is performed, which is revealing a pattern consistent with Mobitz type 2 or the infranodal heart block. Which of the following characteristics is typically not observed in this patient? Right? The options are: the problem lies just below the AV node and the lesion is in the bundle of His. The PR interval conduction is from the SA node to the exit of the AV node, so there is no change in the PR interval. Third option, the PR interval is increased with a sudden missed beat and the process continues. The characteristic feature is that the PR interval before and after the missed beat, it is equal. So the point is, which of the following is not observed in this patient? So it is a Mobitz type 2 AV nodal block. Mobitz type 2 AV nodal block is that where the block is present below the bundle of His, and that is the reason why the PR interval will remain constant. There is no change in the PR interval and the PR interval will be within the normal limit. And so the problem lies below the AV node, that the lesion is in the bundle of His. And if you take the PR interval is increased, this is a wrong statement. PR interval is not increased in case of Mobitz type 2 AV nodal block, right? There will be a missed beat, but you will not have increase in the PR interval in case of Mobitz type 2 AV nodal block. And the characteristic feature is that the PR interval before and even after the missed beat, it is equal, right? Before and after the missed beat, it is equal. Now let me show you the ECGs of all the types of the AV nodal block. In case of the first degree AV nodal block, the abnormality is in the internodal fibers, right? The abnormality is in the internodal fibers where there will be prolongation of the PR interval. Then we have the second degree AV block. Second degree AV block, again we have two types, Mobitz type 1 and as well as Mobitz type 2 AV nodal block. So you take Mobitz type 1 AV nodal block, which is also called as Wenckebach's phenomena. There will be progressive prolongation of the PR interval and there is drop in the QRS complex. That is what is observed in case of Mobitz type 1. Whereas in case of Mobitz type 2, in case of Mobitz type 2, the PR interval, it remains constant. And PR interval, it remains normal as well. So PR interval is constant and PR interval is normal, but there is intermittent drop in the QRS complex. That is what is observed in case of Mobitz type 2. Whereas you take third degree AV block, in third degree AV block, this is nothing but the complete heart block. So in case of the complete heart block, there is no association between the atria and as well as ventricle. So atria will contract on its own and ventricle will contract on its own, and that is what is observed in case of the complete heart block. So this will be the ECG changes in first degree, second degree and as well as the third degree AV block. So out of which you take this Mobitz type 2. Mobitz type 2 is considered as the infranodal block, right? It is considered as the infranodal block. So this is about the first important question related to the AV block. And the next question is, we have a 65-year-old male patient with a history of the heart failure. He presents to the cardiology clinic for evaluation. His echocardiography reveals severe left ventricular dysfunction with widening of the QRS complex. And the cardiologist recommends the implantation of the pacemaker to improve the cardiac function. Which of the following sites would be the most appropriate for the placement of the double lead pacemaker in this patient? So if you take these pacemakers, like we have the single lead pacemaker, dual lead pacemaker and triple lead pacemaker. Now, where is that if you are placing a double lead pacemaker, the double lead pacemaker, it has to be placed in the right atrium and as well as in the right ventricle. And within the right ventricle also, where is it placed? It is placed at the apex. Whereas, if you want to place a single lead pacemaker, the single lead pacemaker, the placement has to be done within the right ventricle. Whereas the dual lead pacemaker, it is placed in the right atrium and as well as the right ventricle. And where is that you will place a triple lead pacemaker? The triple lead pacemaker, it is placed in the right atrium right ventricle, and as well as the left ventricle. Right, and as well as the left ventricle. So this is about the single lead, dual lead and triple lead pacemaker, but the one which has been recently been followed in the recent times is the dual lead pacemaker has been followed very commonly, right, and it has been found to have a very good outcome as well, right. Next question. A 60-year-old male patient presents to the emergency department with palpitations and shortness of breath. The ECG reveals atrial flutter with rapid ventricular responses. The patient's blood pressure is stable and he is hemodynamically well. Which of the following interventions would be most appropriate as the first line treatment for rate control of this patient? The options are the intravenous esmolol, chemical cardioversion with intravenous amiodarone, electrical cardioversion with biphasic DC shock, anticoagulation with the unfractionated heparin, right? So now this particular patient is in a state of the atrial flutter, right? And the individual is hemodynamically well, right? The individual is hemodynamically well. So in a patient with atrial flutter presenting with the palpitations and as well as shortness of breath, what is very important is rate control is very important, and as well as the rhythm control is also very, very important. But out of these two, rate control is the one which has to be achieved first. And here the individual is hemodynamically stable. When the individual is hemodynamically stable, the electrical cardioversion with biphasic DC shock is not required. So electrical cardioversion is required only when the patient is having the hemodynamically instability. If the individual is hemodynamically unstable, then electrical cardioversion is required. And so because the individual is hemodynamically stable, the drug that is used for the rate control is the beta blocker, that is intravenous esmolol has to be used, right? And what are all the drugs which are given for the rate control? So for the rate control, the drugs that are very important is the beta blockers, and as well as non-dihydropyridine calcium channel blockers, that is diltiazem and as well as the verapamil, right? And why is that we are giving this esmolol first? It is the one which will act rapidly and effectively controls the heart rate in patients with atrial flutter, and it will control the heart rate and it will not compromise the cardiac output, right? Without compromising the cardiac output, it will control the heart rate, and that is the advantage of this, the esmolol, right? Whereas you take this amiodarone. Amiodarone is the one which is required for rhythm control, right? And it is not typically the first line treatment for the acute atrial flutter. So rhythm control is done after you have initiated for the rate control, and electrical cardioversion is being done when the individual is hemodynamically unstable. Right, when the individual is hemodynamically unstable, then the electrical cardioversion with biphasic DC shock is very much required. Then you take this anticoagulation. Anticoagulation is important in atrial flutter, especially before cardioversion, to prevent the thromboembolic events, right? But again, this anticoagulation is not the first line treatment for acute management of atrial flutter with rapid ventricular response. Okay, so before the cardioversion, the anticoagulation has to be given. So the learning objective is this particular protocol has to be followed, that is RACE. So R stands for the rate control, A stands for the anticoagulation that has to be given before the cardioversion, right? So cardioversion is nothing but your rhythm control. Rhythm control, it is being done either by the amiodarone, right, or by the ibutylide, right, or by the ibutylide. This will restore, these two drugs will restore the normal heart rhythm. And next is the E stands for the electrical cardioversion. So electrical cardioversion, if you observe in case of the atrial flutter, you have to give only when the individual is hemodynamically unstable, and that electrical cardioversion that we give is 25 to 50 joules, right? 25 to 50 joules is the one that has to be given to restore the normal heart rhythm when the individual is hemodynamically unstable. So this is about the treatment in case of the atrial flutter, right? Next question. We have a 14-year-old girl presents with a 2-day history of fever and as well as the joint pain. Her mother mentions that the girl has the sore throat 3 weeks ago, which resolved on its own. On examination, there is an evanescent macular skin rash on the abdomen that appears and disappears, and there are also non-tender nodules on the elbow bilaterally. What is the most likely diagnosis? Rheumatoid arthritis, infective endocarditis, Kawasaki disease, and then the acute rheumatic fever. So here the individual is having the history of sore throat 3 weeks ago, right? History of sore throat 3 weeks ago. So this is very much suggestive of the acute rheumatic fever. So this acute rheumatic fever, it is a multi-system inflammatory disease that is delayed sequelae of group A beta hemolytic streptococcal infection. Okay, so this is secondary to group A beta hemolytic streptococcal pharyngitis. And whenever you don't give the antibiotic treatment to streptococcal pharyngitis, there is increased risk of development of this, the acute rheumatic fever, right? And the diagnosis of acute rheumatic fever, it is based on the revised Jones criteria. Okay, and according to the revised Jones criteria, what is required for the diagnosis is the presence of the 2 major manifestations. Okay, so the presence of 2 major manifestations or 1 major, right, or 1 major plus 2 minor manifestations, they indicate a high probability of an initial acute rheumatic fever illness in any risk population. Now, what are the major criteria? Presence of arthritis. So this particular patient is presenting with the history of the joint pain. This is one of the major criteria. And next is the macular skin rash, which is nothing but the erythema marginatum, another important major criteria. And there is non-tender nodules. It is another important major criteria. So what are all the major criteria according to the revised Jones? Number 1, presence of clinical or subclinical arthritis, then carditis, then erythema marginatum, subcutaneous nodules, and Sydenham's chorea. So out of 5, if 2 are present, then we consider that the individual is having the rheumatic fever. Then what are the minor criteria? Minor criteria will be polyarthralgia, fever, raised CRP, raised ESR, and prolonged PR interval. So this will be the minor criteria, right? So now, how will you rule out the other options? You take rheumatoid arthritis. What is the age of the patient? That is 14-year-old. This rheumatoid arthritis mainly affecting the small joints. It is commonly observed in the middle-aged women. And the common presentation in patients with rheumatoid arthritis will be early morning stiffness. And there is no association of the sore throat. There is no association with the streptococcal infection in case of rheumatoid arthritis. Whereas you take infective endocarditis, it is caused by the infection of the heart valve. And these patients with infective endocarditis, they present with high-grade fever and they have the heart murmurs. Apart from high-grade fever and heart murmurs, the other important manifestations include the Osler's nodes, subungual splinter hemorrhages, Janeway lesions. They are characteristic in case of the infective endocarditis. Next is Kawasaki. Kawasaki, it's a medium vessel vasculitis which is common in children. Presentation in case of Kawasaki will be fever, rash, and there will also be coronary artery aneurysms, right? So there will also be presence of the coronary artery aneurysms. Okay, so these are the features that you will have in case of the Kawasaki disease. So the answer in this particular question will be the acute rheumatic fever, right? Coming on to the next question. We have a 50-year-old male with history of rheumatic heart disease presents with 3 months history of fatigue, night sweats, and low-grade fever. He received antibiotics for a suspected respiratory infection, but his symptoms are still persisting. There is a diastolic murmur which is heard best in the aortic area. Blood cultures obtained before antibiotics were initiated did not yield any growth. The transesophageal echocardiography revealed aortic valve vegetation. Which of the following is not responsible for this disease? The options are Hassek group, Pseudomonas, Bartonella, and Mycobacterium chimera. So the individual is having history of rheumatic heart disease, presenting with a 3 months history of fatigue, night sweats, and low-grade fever. right? And there is a suspected respiratory infection for which the individual has received the antibiotics, and there is diastolic murmur in the aortic area, and blood cultures are obtained before the antibiotics are initiated and did not yield any particular growth, okay? And TEE is showing that there is presence of the aortic valve vegetation. So this aortic valve vegetation causing the diastolic murmur makes that the individual might have developed the development of aortic regurgitation, secondary to the vegetations which are caused by the infective endocarditis. Now, why is that I am using the word this infective endocarditis is because the individual had definitely the rheumatic heart disease, but at the same time, the patient is also having the fever, right? The patient is also having fever, okay? So, presence of fever with vegetations on transesophageal echocardiography suggestive of the infective endocarditis, right? Now, and what type of infective endocarditis here? Before the antibiotics have been initiated, the blood cultures were obtained but did not yield any growth. So this is suggestive of the culture negative, right? This is suggestive of the culture negative infective endocarditis, right? Now, if you take this infective endocarditis among the organisms which has been given to you, HASEC is the one which can cause infective endocarditis, Bartonella and Mycobacterium chimera, whereas the Pseudomonas, it is not typically associated with infective endocarditis, right? This Pseudomonas aeruginosa is more commonly associated with the other infections. What are those other infections which are associated with Pseudomonas? It is associated with the respiratory tract infections. It is associated with the urinary tract infections, right? So this Pseudomonas is not a typical causative organism for infective endocarditis, especially in the culture negative cases. Whereas the other organisms like HASEC, that is Haemophilus, Aggregatibacter, then Cardiobacterium, Echinella and Kingella. So these are associated with infective endocarditis, and they are the one which are responsible for the culture negative endocarditis. Then you take this Bartonella. Bartonella, they are known to cause the infective endocarditis, including the culture negative cases. These organisms, that is Bartonella, they are associated with conditions like cat scratch disease, right? Associated with cat scratch disease, and they can lead to culture negative results in the blood culture. That is what is the Bartonella Hensley. Then next is Mycobacterium chimera. So Mycobacterium chimera can still be responsible for the culture negative cases, especially in the context of the prosthetic valve endocarditis. Okay. So in prosthetic valve endocarditis, the Mycobacterium chimera is one of the important organism. But this Mycobacterium chimera is a rare compared to the other causative organism, but still it can lead to the culture negative results. But among the organisms which has been given to you, Pseudomonas is not associated with the development of the infective endocarditis. And if you see the organisms that are causing culture negative endocarditis, some species of the Streptococcus like Granulicatella and as well as Abiotrophia species. Then the HASEC group of organisms, that is Haemophilus, Aggregatibacter species, Cardiobacterium, Echinella and as well as the Kingella, and followed by that the other organisms like Bartonella, Trophima vipulae, Corynebacterium, Propionibacterium, then Mycobacterium chimera. So these are the organisms which are associated with the culture negative endocarditis, okay. Then coming on to the next question, we have a 40-year-old man presenting with fever, chills, weakness and shortness of breath for 2 weeks. He had recently undergone the valve replacement for mitral valve prolapse. 3 weeks ago, he had a dental procedure. His blood pressure is 100 by 65 millimeters of mercury, pulse is 55 per minute and the body mass index is 21 kg per meter square. On examination, he has hemorrhagic macules on his palms. Which of the following is the finding are also seen in the patient? Janeway lesions, Osler's nodes, erythema marginatum, the erythema nodosum. Now, so the patient is having the hemorrhagic macules on the palms. And what is the background history? The individual is having fever, chills, shortness of breath for 2 weeks, undergone valve replacement for mitral valve prolapse, right? So 3 weeks ago, he had undergone a dental procedure, and this is the following manifestation right now. So presence of, okay, what is this entire picture suggestive of? the entire picture is suggestive of the individual had developed the infective endocarditis. And secondary to infective endocarditis, presence of the hemorrhagic macules on his palms, it is suggestive of the Janeway lesions. So these Janeway lesions, how do we describe them? As they are the cutaneous manifestations of the infective endocarditis. And these particular Janeway lesions, they are the irregular, they are the hemorrhagic macules, which are involving the palms, and they can last for weeks, right? And they can last for weeks. And these lesions, they are caused by the septic microemboli from the valvular lesions. Okay, so these Janeway lesions, they are caused by they are caused by the septic microemboli from the valvular lesions, right? And cultures of the specimens are usually positive. And if you take Janeway lesion histologically, what will be there? Janeway lesion histologically, it consists of the microabscess in the dermis with the thrombus of the small vessels without vasculitis. So Janeway lesions, what do they contain? They consist of the microabscesses in the dermis with thrombosis of the small vessels. Now, how does these Janeway lesions appear? So this will be the Janeway lesions. Right, so this will be the Janeway lesions. And next important is the Osler's nodes. These Osler's nodes, they are present in the pulp of the fingers. And these Osler's nodes, which are present in the pulp of the fingers, they are very painful. And they are associated with septic microemboli and dermal microabscess formation. And these Osler's nodes, they were discovered by Dr. William Osler. And these Osler's nodes, they are very much painful. Right, they are very painful, and they are present in the pulp of the fingers, and they last for days. And these nodes, they result from the immunological phenomena. Right, these nodes, they result from the immunological phenomena. So this is about the Osler's nodes. Then next is the other option was erythema marginatum. Erythema marginatum, it is one of the criteria required for the diagnosis of the rheumatic fever but not the infective endocarditis, right? And next important is the erythema nodosum, which is present over the lower limbs, over the shin of the tibia. And this particular, the erythema nodosum, it is observed in, or it is a hypersensitivity reaction secondary to the tuberculosis. Right, secondary to tuberculosis. And if you observe the non-cardiac manifestations of the infective endocarditis, that includes the Janeway lesions, subungual hemorrhages, Roth spots, Osler's nodes, stroke, regional or abdominal pain, meningitis, and the mycotic aneurysm. So these are the non-cardiac manifestations of the infective endocarditis. Okay, so this is about the so this is about the question related to the infective endocarditis, where there is presence of the hemorrhagic macules on his palms, right, with the background history of the infective endocarditis. Next question. Okay, so we have a 45-year-old male patient with the history of chronic alcohol abuse. He presents to the emergency department with bilateral ankle or the pedal edema. And there is discomfort in the right upper quadrant of the abdomen, and there is also orthopnea. Chest auscultation reveals bilateral crepitations, a loud S1 and a pansystolic murmur. A small correction here, it is soft S1. And point of maximum impulse is hypokinetic and diffuse. What is the most likely diagnosis? The alcoholic cardiomyopathy, right-sided heart failure, alcoholic hepatitis, acute pulmonary edema. So the patient is having chronic alcohol abuse, and the patient is having the features of both right and as well as the left heart failure. So right heart failure like pedal edema, right, discomfort in the right upper quadrant of the abdomen, and these are the features of right heart failure. Whereas if you take this orthopnea, that is a feature of the left heart failure. And chest auscultation is revealing bilateral crepitations, that is also the feature of the left heart failure. right? And the individual is having a soft S1 and a pansystolic murmur with point of maximum apical impulse. It is hypokinetic and as well as diffuse. With a background history of the alcohol, you need to think of the alcoholic cardiomyopathy. And why there is pansystolic murmur and soft S1 and hypokinetic and diffuse apical impulse is due to development of dilated cardiomyopathy secondary to alcohol. Right, development of dilated cardiomyopathy secondary to the alcohol, right? So point of maximum apical impulse, it is hypokinetic and as well as diffuse. That is what is observed in cases of the DCMP, right? Whereas you take right-sided heart failure, the second option. In right-sided heart failure, the individual will have pedal edema. The individual will have right upper quadrant pain. In right-sided heart failure, they will not have the crepitations on auscultation. They will not have the presence of the orthopnea. So your right-sided heart failure is ruled out. Then coming to the alcoholic hepatitis. In case of the patients with alcoholic hepatitis, where there is inflammation of the liver, which is caused by chronic alcohol consumption, and patients with hepatitis, they do not present with the features of the heart failure. The presentation in case of hepatitis will be only right upper quadrant pain. That is what is seen in alcoholic hepatitis, but they don't have the manifestations of the heart failure. Next, coming to this acute pulmonary edema. Acute pulmonary edema as such, it's a medical emergency which is characterized by sudden accumulation of the fluid in the lungs, right? Which is characterized by sudden accumulation of the fluid in the lungs, and that will lead to a severe respiratory distress. Right, that will lead to a severe respiratory distress, right? And in case of the acute pulmonary edema, you will have the features of left heart failure itself, but you will not have the features of the right heart failure in case of the acute pulmonary edema, right? And if you take the features of dilated cardiomyopathy, so dilated cardiomyopathy is the one which will cause the heart failure with reduced ejection fraction, where the ejection fraction will be less than 40%. And how will be the heart? It is globular, enlarged and flabby heart, and that is due to weakened and dilated chambers leading to reduced pumping efficiency. The histopathology is that they will have the presence of a multinucleated myocytes. The causes, if you observe, alcohol is the most common cause. Then we have genetic mutations, familial causes, idiopathic causes, the sequelae to viral myocarditis. What are the viral infections? That includes the parvovirus B19, HHV6, Coxsackie B virus and COVID-19. And next important is the sarcoidosis. So these are all the etiologies that will be causing dilated cardiomyopathy, and the clinical features will be, they'll have the features of both right and as well as left heart failure. And why is this pansystolic murmur? This particular pansystolic murmur, it is mainly because of the functional MR and as well as the functional TR. And the hypokinetic diffuse point of the maximal apical impulse is mainly because of dilatation of the chambers, and the LV which is dilated, it is having LV dysfunction with ejection fraction less than 40%. So that is the reason why there will be hypokinetic diffuse point of the maximal impulse. Okay, so the answer to that particular question is alcoholic cardiomyopathy. Next question. A 35-year-old male presents to the emergency department following syncope at home. The father reports that the patient has had the episodes of palpitations and dizziness in the past. His blood pressure is 80 by 50 millimeters of mercury with no palpable pulse. There is family history of sudden death. Considering that this condition involves mutation in the SCN5A gene, which of the following ECG pattern can be seen? Right. So 1, 2, 3, 4, these are the ECGs. So if you take the first ECG, it is suggestive of the presence of a curved pattern of the ST segment elevation. And this curved pattern, okay, first of all, mutation in SCN5A, this is suggestive of the Brugada syndrome, right? Suggestive of Brugada syndrome. And in case of Brugada syndrome, you will have the curved ST segment elevation. Then you take the second, this is a saddleback ST segment elevation, right? This is a saddleback pattern of the ST segment elevation. So both this curved ST segment elevation and saddleback ST segment elevation, they are the features of the Brugada syndrome. And these patients with Brugada syndrome, they are at increased risk of sudden cardiac death. So the treatment that you need to give in case of Brugada syndrome is, along with the beta blocker, the treatment of choice is the placement of implantable cardioverter defibrillator. then there is ST segment elevation in the third strip. This ST segment elevation in the third strip, it is suggestive of the ST elevation myocardial infarction. Right, so the third one is suggestive of myocardial infarction, whereas you take this fourth one, this is suggestive of the concave ST segment elevation, which is observed in patients with acute pericarditis. Right, which is observed in patients with the acute pericarditis. Okay, now you take this particular Brugada syndrome. So Brugada syndrome, we have two types. One is type 1 and next is type 2 Brugada syndrome. So type 1 Brugada syndrome, you will have coved ST segment elevation, and type 2 Brugada syndrome, you will have a saddleback pattern on the ECG. Right, saddleback pattern on the ECG, where the initial ST segment elevation, that will be followed by downward slope. Right, initial ST segment elevation followed by downward slope. That is what you will observe in case of the type 2 Brugada. Right, and in case of Brugada, they will have the risk of sudden cardiac death, and it is an inherited disorder. That is the reason why you can see the family history of sudden death in patients with the Brugada syndrome in the question which has been given to you. So the treatment of choice is the implantable cardioverter defibrillator. Right, next, coming on to the 9th question. We have a 20-year-old female presents with palpitations and exercise intolerance. She reports the recurrent syncopal episodes since her teenage years. On examination, she has sparse, coarse and frizzy hair and thickened skin on the palm and sole. Her sister died at the age of 25. An echocardiogram reveals right ventricular abnormality including the fatty infiltration and thinning of the myocardium. Which of the following genetic mutation is most likely to be associated in this scenario? The options are the SCN5A gene mutation, MYH7 gene mutation, DSP gene mutation and plakoglobin gene mutation. So whatever this clinical scenario which has been given to you, it is suggestive of Naxos syndrome. In case of the Naxos syndrome, they will have the combination of arrhythmogenic right ventricular dysplasia, they will have the presence of the woolly hair, and whatever you are observing, thickened skin on palm and as well as sole, that is suggestive of palmoplantar keratoderma. Right, palmoplantar keratoderma. These are the one which are present in case of Naxos. And in case of Naxos, arrhythmogenic right ventricular dysplasia, where the right ventricular myocardium is replaced by the fibrofatty tissue, and this particular fibrofatty tissue is at increased risk of the arrhythmias like VT and VF, where the patient will present with the sudden cardiac death. And in order to develop this Naxos syndrome, and as such Naxos, it is an autosomal recessive type of disease. Arrhythmogenic right ventricular dysplasia can also be having autosomal dominant type of inheritance, but the autosomal recessive pattern of disease where you have the arrhythmogenic right ventricular dysplasia is Naxos syndrome. And in Naxos syndrome, the gene that is being mutated is plakoglobin gene is being mutated. Plakoglobin gene is being mutated in case of Naxos, and it is the echocardiography that is the one which will demonstrate the right ventricular myocardium is replaced by the fibrofatty tissue, and the treatment is aimed at managing the arrhythmias and as well as the cardiac symptoms. Okay, and in these patients also the treatment of choice will be the implantable cardioverter defibrillator. Whereas you take the first option, that is SCN5A gene mutation. This is observed in Brugada syndrome, and this is observed in case of long QT syndrome. Right, so in case of the long QT and Brugada, you will have SCN5A gene mutation. Right, whereas you take this MYH7 gene mutation. MYH7 gene mutation, it is associated with the hypertrophic cardiomyopathy, right, which is not consistent with the clinical presentation of Naxos syndrome. Then you take this DSP gene mutation. DSP gene mutation, it is associated with another form of the arrhythmogenic right ventricular dysplasia. Now, what is another form of the arrhythmogenic right ventricular dysplasia or arrhythmogenic right ventricular cardiomyopathy? That is known as, so wherever you have this DSP gene mutation, this is known as the Carvajal syndrome. right? So this is known as the Cardiology syndrome, not the Naxos syndrome. So the above clinical picture is suggestive of Naxos, and in case of Naxos, it is the plakoglobin gene that is being mutated, and this plakoglobin gene mutation is the one which will result in the defective desmosomes. That will result in defective desmosomes, and the treatment of choice here is the implantable cardioverter defibrillator. All right, so the answer is D in this question. And the next question is, which of the following statements is or are true about the conduction of the heart? Depolarization spreads from the apex to the base. Depolarization spreads from the epicardium to the endocardium. Apical endocardium is the first part of the heart to get repolarized. So the only correct statement is the first option, where the depolarization spreads from the apex to the base. And depolarization spreads from epicardium to the endocardium is wrong statement. Depolarization always, it spreads from endocardium to the epicardium, right? Whereas what is that which will repolarize first? It is not the endocardium which will repolarize first, it is the apical epicardium, right? It is the apical epicardium that is what is being repolarized first. So the only true statement here is the first option. So these are some of the very important questions in the topic of the cardiology. So few more important clinical based questions in the cardiology are the following. So we have a 68-year-old male patient with a history of chronic obstructive pulmonary disease. He presents to the emergency department with the palpitations, dizziness, shortness of breath. His heart rate is 110 beats per minute and rhythm is irregular. The auscultation reveals multiple rapid heartbeats. The ECG shows irregular RR interval and P waves are present, but they appear with varying morphology. What is the most likely diagnosis? The options are ventricular tachycardia, multifocal atrial tachycardia, atrial fibrillation, and then the sinus tachycardia. So you take the ECG of ventricular tachycardia, you will not have the P waves at all, right? But the question says the P waves are there, but they are of variable morphology. So it is not suggestive of ventricular tachycardia, because in ventricular tachycardia you will have broad QRS complexes with absent P wave. Then you take the atrial fibrillation. I'll come to the second option in the last. You take in atrial fibrillation. In atrial fibrillation also you don't have the P wave, rather than that you have the presence of the fibrillatory waves, right? Rather than that you have the presence of the fibrillatory waves. And how will be the RR interval in patients with the atrial fibrillation? Yes, it will be irregular RR interval, but P waves are present. This is one point which is going against your atrial fibrillation, because in atrial fibrillation what you will have is the fibrillatory waves but absent P waves. And you take in case of the sinus tachycardia. In case of sinus tachycardia, the RR interval will be absolutely regular. Okay, so you will have the sinus P wave, that means the normal P wave, tachycardia will be there, and the RR interval will be regular. So these are the points suggestive of the sinus tachycardia. Then the answer here is the multifocal atrial tachycardia. Why? Because multifocal atrial tachycardia is one important form of arrhythmia which is very common in patients with the chronic obstructive pulmonary disease, right? And in case of multifocal atrial tachycardia, you will have the different P wave morphologies, and you also have a criteria for that. There should be more than or equal to 3 different P waves, right? There will be more than or equal to 3 different P wave morphologies, right? And at the same time, the heart rate, it should be more than 100 per minute. The heart rate, it should be more than 100 per minute. That is what you will observe in patients with the MAT, that is multifocal atrial tachycardia, which is very common in patients who are having the chronic obstructive pulmonary disease, right? And in patients with this MAT, like what is the treatment? See, if it is secondary to COPD where we cannot give beta blockers, in these patients with MAT, the preferable treatment will be non-dihydropyridine calcium channel blockers, and examples include diltiazem and verapamil. And if suppose if this multifocal atrial tachycardia is not due to COPD, then the preferable drugs will be the beta blockers. Right, the preferable drug will be beta blockers in case of MAT if it is not due to the COPD. So this question, the answer is multifocal atrial tachycardia, right? And this multifocal atrial tachycardia, heart rate should definitely be more than 100 beats per minute. There should be irregular RR interval, and the P wave morphologies will be completely variable, and more than or equal to 3 different P wave morphologies should be there, and presentation will be in the form of the palpitations, right? Next question. A 40-year-old male with history of recurrent episodes of the atrial fibrillation is prescribed Quinidine, an anti-arrhythmic medication. Which of the following statements regarding Quinidine and its features are true? Quinidine is a class 1B anti-arrhythmic drug. It primarily acts by blocking the sodium channels and thereby prolonging the action potential duration. Third, Quinidine is known to cause the shortening of the QT interval on the ECG. Fourth, the most common adverse effects of the Quinidine is hypokalemia. Right. Now, first point, yes, Quinidine is definitely an anti-arrhythmic drug, but this Quinidine, it blocks the sodium channel. It's a class 1 anti-arrhythmic drug, but it is not class 1B, it is class 1A anti-arrhythmic drug, right? And what is the mechanism of action? The Quinidine, it blocks the sodium channels, thereby it slows down the rate of depolarization during the action potential. So it primarily blocks the sodium channels, thereby prolonging the action potential duration. Why? Because it is blocking the entry of the sodium channels, and it is very much required in the treatment of the arrhythmias and as well as management of the arrhythmias. And the Quinidine is known to cause shortening of the QT interval. This is the wrong statement. Now, this particular Quinidine, it is prolonging the depolarization. So thereby what will happen to your QT interval? There will be QT prolongation with the Quinidine. You will not have short QT interval, you will have a long QT interval. Then the most common adverse effect of Quinidine is the hypokalemia. That is a wrong statement. So most common adverse effect of Quinidine, it is not hypokalemia, right? This Quinidine can cause various side effects, including gastrointestinal disturbances, and as well as Quinidine is mainly associated with the development of an important adverse effect that is called synchronism, right? That is what is called synchronism. What is the characteristic features of synchronism? The characteristic features of the synchronism will be number 1, tinnitus, then hearing loss, and then visual disturbances, right? So these are the features of the synchronism, and another important potential adverse effects will be the long QT interval. And this Quinidine, it is obtained from a plant product. And what is this plant product? This is known as the cinchona bark. From the cinchona bark, this Quinidine, it is being obtained, right? And this Quinidine inhibits which particular sodium current? It will inhibit fast inward sodium current, right? It will inhibit the fast inward sodium current. And if you take the adverse effects of this Quinidine, it will cause the QT prolongation, it will cause dizziness, fatigue, and as well as headache. There can be development of the skin rash, weakness and tremors, and there will also be the vision disturbances, right? Whereas you take the electrolyte abnormalities like hypokalemia and as well as hypomagnesemia. Hypokalemia and hypomagnesemia is rare, right? And if it is given at higher doses, it can cause synchronism, which will lead to tinnitus, which is an ear problem, which will lead to diplopia, which is an eye problem, and this will also cause the excitation of the central nervous system, right? So this is about the Quinidine and as well as its adverse effects. Next question. A 25-year-old pregnant woman presents to the obstetric clinic for a prenatal checkup. She has history of bipolar disorders. On prenatal ultrasound, the fetus exhibits cardiac abnormalities, including an inferiorly displaced tricuspid valve, tricuspid regurgitation, and a small right ventricle and WPW syndrome. Now, which of the following drugs is most likely to be responsible for the following finding. The options are lithium, valproate, captopril, then the carbamazepine. So this is in case of 25-year-old pregnant women having bipolar disorders. There is distal displacement of the tricuspid valve. So all these points, and one more important point is WPW syndrome is present. So all these points, they are suggestive of the Epstein's anomaly. So in Epstein's, you will have distal displacement of the tricuspid valve, and there will be atrialization of the right ventricle, and there will be small right ventricle, and the ECG will show in patients with Epstein's there is increased chances of the presence of an accessory pathway in case of Epstein's, right? And presence of the accessory pathways in Epstein's, it is nothing but the WPW syndrome. And what is the drug which is associated with the development of Epstein's anomaly is, that is the lithium. So lithium, it is very much important, known for the congenital heart disease, that is Epstein's anomaly, right? So this Epstein's anomaly occurs mainly when the patient takes this lithium in the first trimester of the pregnancy, right? Where there will be in distal displacement of the tricuspid valve, and there will also be tricuspid regurgitation as well, right? Whereas you take this valproate. Valproate is an anti-epileptic drug that is being associated with increased risk of neural tube defects, right? Increased risk of neural tube defects. Whereas you take this captopril. Captopril is an ACE inhibitor. What this captopril is associated with, the captopril, when it is taken in pregnancy, it is associated with renal agenesis, right? Associated with renal agenesis. That is the reason why these ACE inhibitors are absolutely contraindicated in pregnancy, because it can cause renal agenesis in the fetus. Whereas you take this carbamazepine. See, carbamazepine, it is more commonly associated with the neural tube defects during the pregnancy, right? So it is the lithium which is associated with the development of the Epstein's anomaly and increased risk of the pre-excitation syndromes, that is the WPW syndrome, right? Moving on to the next question. We have a 3-week-old infant is brought to the clinic due to bluish discoloration of lips, skin and nail beds. The baby tires quickly during the feed and often appears fatigued. On examination, the infant is visibly cyanotic, and cardiac auscultation reveals the single sound, first heart sound, and single S2 as well, and a systolic ejection murmur. There is cardiomegaly on the chest X-ray. What do you think is the diagnosis? The options are tetralogy of Fallot, patent ductus arteriosus, tricuspid atresia, and as well as coarctation of aorta. See, first of all, what type of congenital heart disease is this? It is a cyanotic congenital heart diseases, right? So cyanotic congenital heart disease, like we have 5 T's, that is tetralogy of Fallot, then tricuspid atresia, transposition of the great arteries, truncus arteriosus, then total anomalous pulmonary venous connection. So these are the 5 T's which are the cyanotic congenital heart diseases. Now, so this patent ductus arteriosus, coarctation of aorta is ruled out. Yes, even in patent ductus arteriosus also, there can be development of cyanosis whenever there is development of 𝐒𝐮𝐬𝐺, right? So when there is a scenario of development of 𝐒𝐮𝐬𝐺, then you have this, the patent ductus arteriosus. But whenever there is 𝐒𝐮𝐬𝐺, you know, there will be development of pulmonary hypertension and there will be loud P2 as well, right? Now, so the probability is option A and as well as the option C. But you take the presence of single loud S1, this will rule out the tetralogy of Fallot, right? So because in case of the tetralogy of Fallot, like what all will be the problems? There will be ventricular septal defect, there will be right ventricular hypertrophy, subpulmonic stenosis, and overriding of aorta. You don't have any abnormality in the first heart sound in case of the tetralogy of Fallot. So this one important point, the presence of the single loud S1 will completely rule out this tetralogy of Fallot. So whatever the features which has been given, they are suggestive of the tricuspid atresia. So tricuspid atresia is that where the tricuspid valve is absent or the tricuspid valve is poorly developed, right? And this tricuspid atresia results in the absence of right atrioventricular connection, right, will because the tricuspid valve is absent, there is absence of the right atrioventricular connection. So in tricuspid atresia, a single functional ventricle pumps the blood to systemic circulation, resulting in the early neonatal cyanosis. So whatever the clinical findings like central cyanosis, chest X-ray showing cardiomegaly, presence of the single loud S1 and single S2, right? What is that single S2 that you will have in case of the tricuspid atresia? That will be A2. The P2 component will be absent, right? And the next is the ejection systolic murmur. So the presence of a systolic ejection murmur, which can be associated with turbulent blood flow through the malformed tricuspid valve. So all these are the points suggestive of the tricuspid atresia, right? So it is not tetralogy of Fallot, because in tetralogy of Fallot you will not have a single loud S1. It is not patent ductus arteriosus because it is acyanotic congenital heart disease. And in coarctation of aorta, the presentation will not be in the following manner, whichever has been described. Okay, so because in patent ductus arteriosus, like what is the murmur that you will have? A continuous murmur. Even in case of the coarctation of aorta, what is the murmur that you will have? You will have a continuous murmur. And in case of coarctation of aorta, what is that you will have is, you will have differential in the pulse. If you take the coarctation is present distal to the left subclavian artery, then there will be radiofemoral delay. Whereas if the coarctation is present proximal to the left subclavian artery, then it will be radioradial delay. So it all depends upon where exactly the coarctation is being present. Okay, so the answer here is the tricuspid atresia. And in case of tricuspid atresia, it is the surgical treatment which is required after the minimal medical management. Okay, so moving on. So this question answer is the tricuspid atresia, right? And what will happen to your second heart sound P2 in case of tricuspid atresia? The P2, it will be soft or it may be absent. Whatever one particular sound that will be there is, only A2 will be there in case of tricuspid atresia, right? Moving on to the next question. So we have a 10-year-old boy is admitted to the hospital for the pneumonia. Further evaluation revealed the presence of the atrial septal defect. The parents deny any prior complaints such as shortness of breath and as well as the chest pain. And there is no family history of heart disease except for the ischemic heart disease in the grandfather. Which of the following is incorrect regarding the atrial septal defect? The options are pulmonary plethora leading to pulmonary artery hypertension, murmur presents early in the course of the disease, flow murmur is present leading to the mid-diastolic murmur, shunt murmur is absent. So the patient is having atrial septal defect. So thereby that will result in shunting of the blood from the left atrium to the right atrium, and that will result in the pulmonary plethora, right, where there is increased flow of blood across the pulmonary artery resulting in pulmonary arterial hypertension, right? Next, murmur presents early in the course of the disease. That is a wrong statement, right? In atrial septal defect, murmur does not present early in the course of the disease. It presents in the later stage, right? It presents in the later stage, and that too it is the flow murmur, right? And that too it is a flow murmur, and flow murmur is present leading to a mid-diastolic murmur. That is a correct statement here, right? So why is this mid-diastolic murmur or flow murmur? Because in atrial septal defect, right atrium is receiving the blood from superior vena cava, inferior vena cava, and right atrium is also receiving the blood from left atrium as well, resulting in the development of increased flow of blood from right atrium to right ventricle. So there will be functional tricuspid stenosis resulting in mid-diastolic murmur, and the shunt murmur is absent. In case of ASD, the movement of the blood from left atrium to right atrium will not give rise to any murmur, whereas in VSD there will be a pansystolic murmur when the blood is moving from the left ventricle to the right ventricle. That shunt murmur is absent in patients with the atrial septal defect. What is that you will have is, you will have a flow murmur, and that too in the later stages of atrial septal defect. So murmur present early in the course of the disease, it is the wrong statement, right? Moving on to the next question. And in patients with atrial septal defect, what are the other features? In case of the atrial septal defect, on auscultation, you will have the presence of a wide fixed split, right? The presence of the wide fixed split, right? And next important is when you do an ECG, right? When you do an ECG in patients with the atrial septal defect, there can be presence of an incomplete right bundle branch block, right? There can be presence of incomplete right bundle branch block. So that is about the question related to ASD. Now, moving on to the next question. So we have a 66-year-old male was brought to the emergency department with complaints of dyspnea on exertion for 1 day. On examination, there is presence of heaving apex beat and carotid thrill was present. Auscultatory findings showed ejection systolic murmur, the intensity peak in the middle and then downfall, and the presence of the S4 and single S2. The doctor advised transthoracic echocardiography. Which of the following is incorrect transthoracic echocardiographic finding in this patient? So if you take this entire clinical picture, 66-year-old male presenting with dyspnea on exertion, the heaving type of apex beat and carotid thrill is being present. Auscultation showed ejection systolic murmur, right, which is peaking in the middle, and there is presence of S4 and single S2. So all these points, they are suggestive of the aortic stenosis. When you do a transthoracic echocardiography in case of the aortic stenosis, it will show you the size of reduced orifice. Actually, the normal aortic valve area, this is around 3 to 4 centimeters square, right? If the aortic valve area is less than 2 centimeters square, this is suggestive of the aortic stenosis. Aortic valve area less than 2 centimeters square is suggestive of the aortic stenosis. That is, and if the aortic valve area, if it is 1.5 to 2 centimeters square, this is suggestive of mild aortic stenosis. And if the aortic valve area, if it is around 1 to 1.5, then it is suggestive of moderate aortic stenosis. And if the valve area is less than 1 centimeter square, this is suggestive of the severe aortic stenosis. Right, this is suggestive of the severe aortic stenosis. Okay, so now this will show, the transthoracic echocardiography will show you the size of the reduced orifice. That is a correct statement, or that is a true statement. The ejection velocity is more than 4 meters per second. Yes, that is very much suggestive of the aortic stenosis, and that can be made out in the 2D echo. And transvalvular gradient is more than 40 millimeters of mercury. See, if you observe the gradient between the left ventricle and aorta, it should be around 5 millimeters of mercury. To call it as aortic stenosis, the gradient between the left ventricle and as well as the aorta, it should be more than 10 millimeters of mercury. And if the gradient is more than 40 millimeters of mercury, it is very much suggestive of the severe aortic stenosis. And it shows the shape of the reduced orifice. No, the 2D echo will not show you the shape of the reduced orifice. It will just tell you the size of the reduced orifice. Okay, so that is what we are doing the 2D echo for. That is mainly to show the size of the reduced orifice, not the shape of the reduced orifice. So the incorrect statement about transthoracic echocardiography in patients with the aortic stenosis is, it shows the shape of the reduced orifice. It is the wrong statement. Coming on to the next question. Right. So a 6-month-old infant is brought to the pediatric cardiology clinic for evaluation of the heart murmur noted by the parents. Upon examination, the physician identifies the ventricular septal defect. Further assessment is required to determine the specific type of VSD present in the infant. So which of the following types of the VSD is most common? Perimembranous, muscular, supracrystal, and as well as the sinus venosus type. So the most common type of VSD is the perimembranous type of VSD, right? And this perimembranous type of VSD, it is also known as, right, it is also known as membranous or subaortic type. Right, membranous or subaortic type, and this type of VSD is located adjacent to the membranous septum, and it is typically found in the membranous portion of the ventricular septum, right? And this membranous type of the VSD, this will account for majority of the VSD, and this will account for nearly around 70 to 80% of all the VSDs, right? This will account for 70 to 80% of all the VSDs. Then next one is the muscular VSDs. The muscular VSDs, they are also known as trabecular VSDs. They are also known as mid-muscular VSDs. So this muscular VSDs, which is trabecular or mid-muscular VSDs, they are located within the muscular portion of the ventricular septum. Right? They are present in the muscular portion of the ventricular septum. While they are a common type of VSD, they are not most prevalent. So which is more prevalent? That is the perimembranous. The other one is the supracrystal. Supracrystal VSD is also known as conal VSD or outlet VSD, and they are situated above the level of the aortic valve, and they are less common than the perimembranous VSDs. Then we have the sinus venosus. The sinus venosus defects are the type of the atrial septal defect, but not the VSDs. So sinus venosus is, it is a form of ASD but not the VSD, and they involve the atrial septum. The sinus venosus type of ASD, they involve the atrial septum, specifically the area where the superior or inferior vena cava enters the right atrium. So sinus venosus defect are a type of the ASD, right? So this is about the question related to the atrial septal defect. Moving on to the next question. So we have a 56-year-old male presents to the emergency department with sudden increase in blood pressure and severe headache. On physical examination, you notice bilateral retinal hemorrhage and proteinuria. The patient also complains of confusion and dizziness. The image depicts the pathological specimen collected for further analysis. What condition should be considered in this patient based on the clinical presentation? So the patient is having sudden increase in blood pressure, and there is severe headache, and there is bilateral retinal hemorrhages, and as well as the proteinuria as well, and the patient is confused and having dizziness, and this is the pathophysiology specimen for further analysis. So the patient is having hypertension, the patient is having bilateral retinal hemorrhage, proteinuria and confusion. So along with hypertension, eye is affected, kidneys are affected, and as well as even the brain is also affected, right? So these are the points to tell you that the individual has developed the malignant hypertension. See, if it is essential hypertension, you don't have ophthalmic involvement, you don't have kidney involvement, and you don't have CNS involvement. If it is hypertensive encephalopathy, you will have only CNS involvement, you don't have this retinal involvement, and you don't have the renal involvement in the form of proteinuria. And atherosclerosis, it is one of the risk factors for the development of the hypertension. But in case of atherosclerosis, you will not have, along with hypertension, you will not have this end organ damage, only in case of the picture suggestive of the atherosclerosis. So there is an end organ damage here. There is retinal hemorrhage. This retinal hemorrhage, it is suggestive of the retinopathy. There is proteinuria, which means there is hypertensive nephropathy. There is also CNS manifestations that is suggestive of the hypertensive encephalopathy. So all these three together, we tell it as the malignant hypertension, right? And pathologically, this syndrome is associated with diffuse necrotizing vasculitis, right? So what is that you are able to make out in this pathological specimen is the fibrin deposition. The fibrin deposition in the arteriolar wall, and it is also associated with diffuse necrotizing vasculitis. So this will be the pathological specimen that you will have in patients with the malignant hypertension. So why is it not the essential hypertension? It typically does not present with sudden onset severe symptoms. Retinal hemorrhages, proteinuria, confusion, they are not the features of essential hypertension, right? So that is the reason why the answer is the malignant hypertension in these patients. Now, moving on to the next question, we have a 58-year-old male presents to the clinic for a routine follow-up. He has history of hypertension and type 2 diabetes mellitus for the past 10 years. His blood pressure is currently 150/90 and his fasting blood glucose is 160 milligrams per deciliter. On further examination, his serum creatinine level is 1.5 milligram per deciliter and estimated GFR of 45 ml per minute per 1.73 meter square. Which of the following is most appropriate target blood pressure for this patient? So the options are less than 140/90, less than 130/80, less than 140/80, less than 130/75. So the patient is diabetic. Blood pressure is 150/90. And the GFR is reduced to less than 45. So it is the feature suggestive of the diabetic nephropathy. It's a feature suggestive of the diabetic nephropathy. So what is the target blood pressure in case of the diabetic nephropathy is less than 130 by 80. So this is the guidelines from the American Diabetic Association, or this is the guidelines from the American Heart Association. So the point suggestive of diabetic nephropathy is the GFR which is being reduced. The estimated GFR, normal individual, it should be more than 90. So it is like around 90 to 120 ml per minute per 1.73 meter square, right? And the creatinine, it will be elevated in patients with the diabetic nephropathy. So whenever there is diabetic nephropathy, the blood pressure should be less than 130 by 80 strictly. If you don't maintain the blood pressure as less than 130 by 80, then there is progression of the diabetic nephropathy to a stage of the end stage renal failure, right? And in cases of, like in the previous question, we were discussing about the malignant hypertension. Okay, so in case of the malignant hypertension, how much blood pressure should be reduced? So the blood pressure should be reduced by 20 to 25% over 2 hours. Right, the blood pressure should be reduced by 20 to 24% over 2 hours. Okay, so the answer in this particular question is less than 130 by 80. So moving on to the next question. So we have a 65-year-old male patient with history of hypertension presents to the emergency department with sudden onset, right-sided weakness and slurred speech within 4 hours. The imaging confirms an ischemic stroke. The patient's blood pressure upon arrival is 200 by 120 millimeters of mercury. What is the appropriate management strategy for this patient based on the current guidelines? The options are, so okay, first of all, what is the problem here? The onset of right-sided weakness and as well as slurred speech within 4 hours. Blood pressure is 200 by 120 and imaging shows that it is ischemic stroke. So within 4 hours the patient has presented. So he is an ideal candidate for a thrombolytic therapy with the tissue plasminogen activator. But how much should be the blood pressure whenever you want to start thrombolysis in a patient with the ischemic stroke? You see the options. Immediately initiate the thrombolysis regardless of the blood pressure level. No, it is incorrect statement. When you have a blood pressure of around 200, if you start thrombolysis, there is chance of the ischemic stroke turning into a hemorrhagic stroke. There can be rupture of the blood vessels. No. So first option incorrect. Lower the blood pressure with IV nicardipine to less than 185 by 110 before considering the thrombolysis. This is the correct statement. So you need to reduce the blood pressure to less than 185 by 110. Then you can go ahead with the thrombolysis in patients with the ischemic stroke, right? And you take the third option. So lowering the blood pressure to less than 160 by 90 before considering thrombolysis is not required. You can reduce the blood pressure to less than 185 by 110 and then you can go ahead with the thrombolysis, okay? And initiate thrombolysis only if the blood pressure is within the range of 130 to 140. See, this blood pressure is required in cases of the ICH, okay? So in patients or in cases of intracerebral hemorrhage, right, there you require the blood pressure of nearly around 130 to 140 millimeters of mercury, but not for thrombolytic therapy in case of the ischemic stroke, okay? So you see in case of ischemic stroke, the target blood pressure before starting thrombolysis will be like less than 185 by 110 millimeters of mercury. And to lower the blood pressure, you need to give the IV nicardipine, right? And if the blood pressure is around 220 by 130 is not a candidate for thrombolytic therapy. And next is the intracerebral hemorrhage. If the patient is having the intracerebral hemorrhage, the blood pressure has to be reduced to around 130 to 140 millimeters of mercury, okay? So these are some of the important clinical based questions in the cardiology. Thank you very much.